for joining us tonight for our update on alcohol and other drugs pregnancy protocols. My name is Sandra Fitzgerald and I'm a clinical editor with Hunter New England Health Pathways, and I work here at the Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the land we are all meeting on and to pay our respects to elders past, present and emerging. We will be using Slido throughout this presentation for a number of reasons. Firstly, as a Q&A tool, so please put all your questions on Slido and these will be addressed at the end of all the presentations during a final Q&A session. There will also be a quiz that comes up while Simon is speaking. And at the end, there will be an evaluation. Now, if you're a GP, this needs to be completed if you want this session to be logged with the RACGP for your CPD hours. So we have two speakers today. We have Dr. Simon Holliday, who is a general practitioner and addictions physician. Simon has been a rural general practitioner in New South Wales for 3 decades. He worked for the Drug and Alcohol Clinical Services of the Hunter New England Local Health District at the Manning Hospital for over 2 decades as a visiting medical officer and then as a staff specialist, and also has a diploma of obstetrics. And our first speaker tonight is going to be Emma Doherty, Research Fellow, Hunter New England Population Health and University of Newcastle Research Intern, Cochrane Public Health. Emma has 15 years experience working in partnership with health services to implement strategies that support the routine provision of preventive care to patients. So I will now hand over to Emma. Thank you so much.
Hi everyone. So yes, I'm Emma Doherty and tonight I'll be presenting on behalf of the Foundation for Alcohol Research and Education, or FARE as they're known. And this is a part of the work that they've been doing with the Every Moment Matters project. And this project is endorsed and funded by the Australian government. So some of you might be aware of the Every Moment Matters project. It was launched last year and they've been running a series of training, women's resources and education campaigns and health professional resources and campaigns. And I thought I would just kick it off by running the TV advertisement that's been on recently.
Every moment matters in your pregnancy, especially this one. I'm a few days pregnant here. I hadn't even done the test yet, but I'd already stopped drinking alcohol. You see, everything you drink, your baby drinks, at every stage of pregnancy. And any alcohol can damage their developing brain and organs. So make the moment you start trying the moment to stop drinking.
So by way of background, the 2020 National Health and Medical Research Council's Australian guidelines to reduce health risks from drinking alcohol have 2 recommendations around alcohol in pregnancy and breastfeeding. So the first recommendation is to prevent harm from alcohol to their unborn child, women who are pregnant or planning a pregnancy should not drink alcohol. And the second recommendation is for women who are breastfeeding. Not drinking alcohol is the safest for their baby. So these guidelines were updated in 2020. The previous guidelines were in 2009. And as you can see, that first recommendation actually is now a stronger recommendation. So the 2000 guidelines said that the safest option was to not drink alcohol in pregnancy. And now it's a quite clear recommendation that women should not drink at all in their pregnancy. This stronger recommendation came about through a review of the evidence and also a consideration that there's a variety of maternal and fetal factors that influence the risks from drinking alcohol when pregnant, making it absolutely impossible to predict the level of risk in an individual. So looking at the prevalence of prenatal alcohol use in Australia, so the largest and latest national survey found that about half of women consume alcohol when they're pregnant. When we look at the time after women are aware of their pregnancy, this is about 1 in 7 women will continue to drink alcohol. Studies have also found that women who are older, who are married, are of higher education and are Caucasian are those that are most likely to drink during their pregnancies. So alcohol in pregnancy, what do we know about it? So alcohol is a teratogen. It freely crosses the placenta to the embryo and fetus. So when a mother drinks, similar blood level concentrations that she experiences, her baby experiences. Alcohol consumption during pregnancy can result in adverse pregnancy outcomes, including miscarriage, stillbirth, and babies being born prematurely, small for gestational age, or with a low birth weight. Prenatal alcohol exposure can also directly cause fetal alcohol spectrum disorder, or FASD, which is a lifelong neurodevelopment condition that impacts the baby's brain and their body. There's also a dose response. So the risk of harm to the fetus from alcohol exposure increases proportionally from 0 with the amount of alcohol consumed and the frequency of consumption. So FASD is the leading preventable developmental disability in Australia. FASD presentations are diverse due to the wide range of prenatal, maternal and child factors that influence prenatal development, coupled with differences in dose and timing of prenatal alcohol exposure. So some of the challenges that people with FASD can experience include physical and emotional development delay, impaired speech and language development, learning problems such as issues with memory and attention, and difficulty controlling behaviour. People with FASD can also be at risk of a range of long-term physical health problems, including cardiovascular, metabolic, allergy and immune problems, to name a few. Just going to run another video, and this is a video from the Every Moment Matters campaign, and this is Nikki's story, who is a carer of a boy with FASD.
His shoe doesn't fit in properly, he's got a bit of a sore eye, the internet's a little bit slow, it doesn't matter what it is, very low tolerance to anything that frustrates him, and which often leads to hysterical tantrums, unbelievable language and name calling, physical threats and sometimes violence. On the other hand, he is a nice little boy and he really wants to do well and he tries so hard to do the right thing, and I'm going to cry because I see what potential this little boy has. Imagine what it's like to have a child who you love, who you get up to in the middle. His shoe doesn't fit in properly, he's got a bit of a sore eye, the internet's a little bit slow, it doesn't matter what it is, very low tolerance to anything that frustrates him, and which often leads to hysterical tantrums, unbelievable language and name calling, physical threats and sometimes violence. On the other hand, he is a nice little boy and he really wants to do well and he tries so hard to do the right thing, and I'm going to cry because I see what what potential this little boy has. Imagine what it's like to have a child who you love, who you get up to in the middle of the night, who at the age of 11 still has night terrors because of the damage to his brain. It's about getting the message out to the world that this is the alcohol. It is a toxic substance. And when it is used in the wrong place, in the wrong time, it has devastating effects.
So although alcohol exposure can impact the developing baby at any stage of pregnancy, there are critical periods that are extra sensitive. So this includes very early in pregnancy, so to 3 to 8 weeks post-conception, when the embryo undergoes rapid cell division and differentiation to provide the foundations of the body's systems. The timing and dose of alcohol exposure both impacts the type of fetal organs and systems affected, as well as the extent to which they're affected. So for example, if alcohol exposure occurs while the heart or the kidneys are developing, this might result in congenital defects of these specific organs. Brain development, which continues throughout pregnancy and into childhood, may be impacted by alcohol exposure at any time during pregnancy. So the RACGP guidelines for preventative activities in general practice recommend that every woman of reproductive age should be considered for preconception care. And such care should include advice to consider abstaining from alcohol, especially if the woman's planning a pregnancy, if she could become pregnant, or she's in the early stages of pregnancy. So when asking a pregnant woman about alcohol in pregnancy, it's important not to assume that she knows not to drink alcohol at all during her pregnancy, or that she isn't drinking. There are a range of contextual factors that can influence drinking behaviours. So it's really important to avoid any judgment, stigma or shame for the woman. You can consider asking about alcohol use before the person knew they were pregnant and after they found out they were pregnant, as changes in drinking behaviour is likely to have occurred during this time. Some potential questions to help start the conversation with a woman could be, was the pregnancy planned or unplanned? How many weeks pregnant were you when you found out? And what health changes have you made since finding out you were pregnant? There are a number of validated assessment tools that can be used to assess alcohol use in pregnancy. One of those tools is the Audit C. So the Audit C consists of 3 questions, which are up there on the screen. So the first question is, how often do you have a drink containing alcohol? If the woman responds never, that's the end of the assessment tool. For women who indicate a response other than never, there are 2 additional questions. How many standard drinks of alcohol do you consume on a typical day when you're drinking? And how often do you have 5 or more drinks on one occasion? For women, they might not comprehend or understand what a standard drink is. So it's also advisable to use a standard drink chart when using the Audit C assessment tool. And there's links to those in the presentation that will be circulated. The Audit C gives a score at the end of the questions. And these scores then provide a risk of alcohol-related harm in pregnancy. So a score of 0 indicates no risk of alcohol-related harm. A score of 1 to 2 indicates low risk. A score of 3 to 4, medium risk, and 5+ high risk of alcohol-related harm in the pregnancy. It's then recommended that you provide advice to women based on their assessed level of risk. It's also recommended that you discuss the alcohol guidelines and the risks to the individual as well as the developing baby. To those women who are already avoiding alcohol, you can give positive feedback to remain alcohol-free in the rest of their pregnancy. And for those who have continued to drink, reinforce the benefits of stopping drinking at any stage during their pregnancy is advisable. You can also continue the discussion to explore their readiness and confidence to refrain from alcohol use in pregnancy. So if a pregnant person is concerned because they've consumed alcohol before they were pregnant, before they knew they were pregnant, provide reassurance that being alcohol-free from the earliest opportunity in their pregnancy is best for themselves and their developing baby. Advise that the risk of harm to the baby is likely to have been low before knowledge of the pregnancy if only small amounts of alcohol had been consumed. And provide positive reinforcement to remain alcohol-free during the pregnancy and to return for support if they're finding it hard to stop drinking. If the patient needs support to stop drinking, consider referral to specialist services. Be aware of your patient's life circumstances and how that may impact on their alcohol consumption. And for those people who are drinking at high risk levels during their pregnancy, it's advisable that they do not stop without medical supervision, as unassisted withdrawal may be life-threatening for both themselves and their developing baby. So if you'd like some more information about the Every Moment Matters project and campaign, you can visit everymomentmatters.org.au. On that website, there are brochures, posters, fact sheets, and evidence summaries on alcohol, pregnancy and breastfeeding, and fetal alcohol spectrum disorders. There is also via the website, free accredited e-learning course for health professionals. So this course consists of 5 modules and 3 case studies and goes for about an hour to an hour and a half. It's also accredited with RACGP, RANZCOG and the Australian Council of Midwives. I'll also draw your attention to the Strong Born campaign. So this was developed by the National Aboriginal Community Controlled Health Organisation, or NACCHO. It similarly has health professional booklets, a community booklet, posters and social media tiles. And all those resources can be found at www.nacho.org.au/FASD/Strongborn. And thank you very much for your time today. I will now pass over to Dr. Simon Holliday to continue the presentation. Thank you.
Thank you, Emma. And thank you, everybody, for giving up your Tuesday evening for our presentation. So, first of all, I'd like to say that here's a quick synopsis of some of the research about FASD. Now, this is not a wind-up. This is probably, this was in a recent journal, but so we're not going to cover all that. But what we're going to do is we're going to talk about alcohol, we're going to talk about pregnancy, look at the epidemiology, some problematic issues about FASD conceptualisation. We're going to talk about sociology and ethnography. We're going to talk about screening, drug and alcohol effects on the pregnancy fetus and the offspring. We're going to talk about management, the postpartum period and lactation, the partner's role, and matters to do with the offspring who've had prenatal alcohol exposure, and some policy responses. So, alcohol is clearly a toxin for humans born and in utero. It is generally unsafe, and Professor David Nutt, who was the head honcho for the UK Advisory Council on Misuse of All Drugs, said alcohol is the most damaging drug in pretty well every Western country. And worldwide, it's responsible for an estimated 3 million deaths and 5% of the global burden of disease. We've heard about the Australian guidelines today. The most recent guidelines are from Canada, which came out this year, and they said a safe amount of drinking is 0, and 2 standard drinks or less per week means one is likely to avoid alcohol-related consequences for yourself or for others. In Australia, only about 30% of women report being abstinent from alcohol in the previous year. And we've done surveys, for example, the National Drug Strategy Household Survey, where just over half of all women consumed who had been pregnant said that they consumed alcohol before they knew they were pregnant. Once people knew they were pregnant, this rate declined to 14.5%. Another study looked at Sydney, Melbourne and Newcastle, metropolitan areas, and particularly higher socio-demographics, found that 60% of women reported drinking alcohol between conception and the recognition of pregnancy. And most of these reported drinking at hazardous levels. After they knew they were pregnant, most stopped, but 18% continued, and 2/3 of those were moderate, but 1/3 of that 18% continued to drink at hazardous levels. So we have to think, is FASD something that is particularly some races are prone to, or some classes of our society are prone to? Well, one, we already mentioned about the Metropolitan study, in that when we looked at those people who were drinking more heavily, it was actually the higher socio-demographic women. But another group of higher socio-demographic people would be doctors. And a study came out last month in the International Medical Journal looking at junior doctors. And 80% of Australian junior doctors were using alcohol, with about 1 in 6 reporting hazardous drinking. Incidentally, general practitioner vocational registrars had lower rates of alcohol drinking than hospital-based registrars. Another study looked very carefully at the US about different racial characteristics and FASD, and when they looked at that, the FASD seemed to be more related to amount of consumption than race. While certain races seem to have a lot of FASD, this research concluded it was probably because we're looking more carefully at these particular racial groups, or it could be issues to do with malnutrition or things like lead exposure. What is this crazy little thing called FASD? Well, it was first described in 3 cases by some dysmorphologists called Doctors Smith and Jones from the University of Washington in 1973. The French actually got there first in 1968, but we usually just recognise the Americans for these sort of things. When we look worldwide, pregnancy is very often unplanned. 44% are said to be unplanned worldwide, and 10% of women drink through pregnancy. So you can see that this is not an uncommon scenario. Of those women who drink through pregnancy, it is said that 1 in 67 will deliver a child with fetal alcohol syndrome, and 1 in 13 a child with a fetal alcohol syndrome disorder, one of the spectrum. And it is estimated that globally, 14,560 new cases are born every day. We don't know what the prevalence is in Australia at this time. And one of the problems is to make a diagnosis of FASD, we need a multidisciplinary assessment. It often takes days and days to make this diagnosis. It's extremely labour intensive, and it's really not very cost effective, and it's probably barely feasible in a Western country, let alone a third world country or remote areas. It has been said that to cope with the new cases, we need 3,357 multidisciplinary diagnostic clinics, which is a big ask, and I think that's worldwide though. I'd like to talk a minute about diagnosis and what do we use diagnosis for? We use diagnosis to tailor our management and improve outcomes for our patients. Well, when I look in my practice, I haven't seen a lot of FASD cases. In my drug and alcohol practice, we often would talk amongst the clinicians and say, oh, do you think it's a bit of FASD? And I had a look at our general practice records, 28,000 best practice records, and we had 3 cases coded as FASD in the whole 28,000. And all of them were diagnosed elsewhere. The guidelines suggest that if your patient is pregnant and drinking, consider referring them to a drug and alcohol clinic. And in my 28 years in the drug and alcohol clinic, I had many, many pregnant women referred, but usually for almost always for opiate problems and not for solo alcohol drinking. So if this diagnosis is meant to tailor management and improve outcomes, it doesn't seem to be effective because we're not making it. And in fact, it's said that we're only picking up about 1% of all FASD diagnoses. And so it's not happening in general practice and certainly not happening in specialist drug and alcohol practice. So what is it about FASD that makes it so hard to get a handle on? Well, I think we've got very good evidence that in humans that alcohol is a big problem in pregnancy, especially for heavy use. It's got serious consequences, and this is backed up by murine studies. That means mice studies. And the mice studies also suggest that low dose drinking or just occasional binge drinking can also be very significant. There are problems in human research though. First of all, given that 60-odd% of women are drinking when they're pregnant, how do we identify who are drinkers and who are the controls? How do we measure alcohol intake and how do we verify it, given that people are tending to underreport? How do we categorise drinking, given that in some countries there's no idea of any people being light drinking, any drinking is wrong. And what time points are we looking at? Preconception? Are we looking at between conception and recognition of pregnancy, first trimester, second trimester? How about if people are drinking and they're smoking or they're using illegal drugs? How about maternal metabolism? If people have alcohol dehydrogenase deficiency, they'll have a very different alcohol level in their blood for the same amount of drinking. How about the blokes? Should the male's role be one of an invisible and innocent onlooker in this whole process? And does prenatal alcohol exposure actually cause many, many different problems? I'd like to take a little look at ethnography or the sociology of what's going on here as well. A lot of conservative or neoliberalist policy would like to see everybody self-regulate all the problems of our society away. And clearly in this area, self-regulation is the duty of the idealised good mother. Here, a woman's pregnant body becomes the threatening other versus the defenceless unborn self of the baby. And responsible mothers should control their unruly bodies by following the advice of their government and their expert doctors. Unfortunately, just giving facts to higher risk drinkers doesn't always work. We actually need to listen to what people are saying when they're high risk drinkers, and there's qualitative research about those women, from those women who continue to drink through pregnancy. They might continue to drink because they have very mixed feelings about pregnant. They might not be wanting to be pregnant. They might be shocked, disappointed. They might have wanted a termination. They might have enough kids already, and one more is just the last straw. Their drinking might well be social and very important for their relationships. They might have a partner or even a succession of partners who all drink heavily and use drugs. Their girlfriends might tell them that they all drank through their pregnancy and didn't have any problems whatsoever. Women might describe multiple traumas and victimisation. Many women have experienced violence and abuse throughout their childhood, throughout their adult life, often from men and even through pregnancy. And some of these women might find when they drink, they can forget some of these problems and they can have a bit of an escape for a while. Poverty and marginalisation often are drivers of heavy drinking as well. And when we look at Aboriginal women, they often have been harmed by the effects of colonialisation and separation. They might describe racism and sexism. Aboriginal women often describe being harmed by social policies such as the destruction of their communities, lack of housing, or the removal of their children by the state, or they themselves may have been removed from their biological family when they were children. I think we need to really get away from just focusing on the women when they're pregnant and irresponsible mothers, and we do need to keep in mind that there's a whole social construct around this particular issue about alcohol and pregnancy. So, we need to get on to screening and the big question of the screen. So there are different ways that we can screen, and Emma has already talked about structured questionnaires, and there's quite a few of these. Here's 4 of them. And with all screeners you have sensitivity and specificity, and none of them are 100%. My understanding is the best evidence about structured screeners is the TACE, and that's certainly the recommended one in the United States. And that's 4 questions about tolerance, being annoyed by you. Have you been annoyed? Have you felt you should cut down? And have you had an eye opener? And you can see that there. You can look it up if you're not familiar with it. I've used it a few times. There are downsides with screening questionnaires, of course, as well. I think GPs get sick of being told to do things by experts, things that work in their expert practice. And it's just another thing we've got to remember. And so when we're told we've got to do this or that, it can be an extra burden. We get guideline fatigue. When we look at all screeners, they're usually designed to pick up problematic drinking rather than low-level drinking, which is what we are thinking about when we're looking at screening for alcohol in pregnancy. We also have to remember that women might feel a sense of shame, guilt, or even fear about reporting their drinking because it might have legal or child custody ramifications if their drinking is disclosed. There is a structured questionnaire that I really would like to suggest, and it's a single question questionnaire. It's recognised and supported in the United States One question, how many times in the past year have you had 5 or more standard drinks? And this is a great question. It takes very little time, and you divide women into people into 3 groups: non-drinkers, dependent drinkers, and then ones you've got to ask some more questions about. You can ask what kind of drink they have, so you get a beverage-specific quantity. How many of each beverage do they have? How frequent is it? And ask about binging. Sounds very much like the Audit C. Other ways of screening, we can use biological markers, and I've listed some of those here. This seems to be quite common, more common in the United States than here, and such to the point where commentators were saying you really shouldn't be doing drug and alcohol testing on newborns to pick up women who have been using drug and alcohol without parental consent. My suggestion for GPs is to stick to your knitting and do the sort of things that we have been taught in medical school and we do time and time again, and let's try and do it better, because we'll get the job done if we do our job well. We need to ask about the 10 major drug groups, and there they are, all listed there. Unfortunately, there is an 11th major drug group, vaping. And vaping is a tsunami on its way. Data released by New South Wales Health at the end of last month showed 16.5% of 16 to 24-year-olds are now current vapers. And this rate 2 years ago was only 4.5%. We've got no idea how vaping is going to affect pregnancy and the offspring. So when you ask about the different groups, the things to ask about is when people started using whatever substance it is, and when they finish using whatever substance it is, or if they're currently using what level they're using. It's really important to explore when they used more, or when they used less, or when they're stopped. And record this really carefully, because this is motivational interviewing gold. The reasons that they increased their drinking or whatever the drug is the reason they're going to relapse very often, and the reason they reduced or stopped is the thing that is going to drive them to make changes this time as well. So, looking at the effects of substance use on pregnancy and offspring, we can look at education, and there are lots of risks to the mother of substances, and these can include psychosocial risks, which include intimate partner violence, financial stresses, legal stresses. Some of these then will drive self-harm, vascular issues like hypertension with some drugs, or venous disease, infections with methamphetamine, syphilis is quite an issue, trauma like accidents, and also people who tend to use substances tend to not attend for antenatal care at all. We do see a clustering of risks, so people who tend to use one of these addictive substances tend to use more, and the more the numbers of addictive substances that people are using, the more likely those women are going to report depression, anxiety, intimate partner violence, and give a family history of drug use. When we try to do statistical multivariate analysis of women to try and tease out what's what, it's very hard to separate genetic transmission from teratogenic effects of the substances. So I've got a list here of the major drugs and their effects on fetuses and so on. And I don't intend to go through them all, but I would like to, you can have a look at them on the afterwards, but it took a while to collect all this material. I do want to look at vaping, and there's very little research, as I said, on vaping and pregnancy. There's a couple of studies that have come out, one that showed a fetus exposed to vaping is going to have more small for gestational age, and another one found that all risks were increased in general, but statistically there was a link between stillbirth and mint and menthol flavoured vapes. I also want to talk about caffeine, and I've got some good news for a change, because there was no associations between caffeine and birth defects in a very large US study, which is good news. So I want to now talk about alcohol and its effect on subsequent effects. Here, most research is done on high-level human drinkers or preclinical studies. A lot of the research is not of a strong basis. For example, with the miscarriage research, this review I looked at 2,145 articles, and they only found 5 articles that met the inclusion criteria. When they looked at those articles, the miscarriage rate increased 7% in the first trimester, 3% in the second trimester, but the risk of the confidence intervals spanned 1, and therefore this didn't reach statistical significance. Another large review of birth defects found there was consistent evidence for abdominal herniation and for cleft palates, cleft lips, and also cardiac defects. But it found less consistent evidence for things such as skeletal defects or gastrointestinal defects. A study of 504 women in New Zealand found that prenatal alcohol exposure was not associated with the age of achieving various gross motor milestones. There were a couple of things though. Binge drinking was associated with delayed verbal development, and infants of non-drinkers had slower language development than infants of light drinkers. And it was thought that that surprising finding was perhaps more related to demographics, for example, the influence of women from the Pacific Islands. There has been other evidence suggesting that there are benefits of light drinking versus abstinence. And one United States study showed less preeclampsia with moderate drinking, and one UK study showed better cognitive outcomes. But by and large, the research is all one way. So coming to management, we've talked a bit about what we would include with education. And when we're talking about education, it's something we do regularly. It reflects the traditional model where a doctor is the authority, the doctor possesses the knowledge, the doctor delivers the education to the patient and tries to manoeuvre the patient to make healthy changes. Unfortunately, this is the antithesis of motivational interviewing. We're also, brief interventions are important to consider. Now, brief interventions are a good thing, like motherhood itself. And which good interventions are the ones that we're meant to use? Well, there's lots of opinions about that. What is a brief intervention? Well, a brief intervention is not a long intervention. A long intervention is one that takes an hour or more. So brief is less than an hour, and they have been described as short as 5-minute intervals and with up to 5 repeat sessions. The Cochrane Review didn't find any particular brief intervention was to be recommended because there was such an inconsistency of the approaches and the outcome measures used. I would like to say something briefly about motivational interviewing. Motivational interviewing is really important. It'll change your practice if you feel more comfortable about it. Rather than the doctor-centred, you're patient-centred. You're allowing the patient to talk themselves into the healthy changes that you'd like to see. There will be a 3-page PDF that will be circulated after this presentation where you can read a little bit about it, and on some of the resources that have been that you'll be linked to, there'll be some training stuff about motivational interviewing. With motivational interviewing, you're listening to the patient. You're finding out what's the difference between what they say they think and what they're aiming for and what they're doing. You're listening for the yes but, resistance comments, pardon me, and rather than arguing with people, you're rolling with the resistance, as it said, which is trying to understand what's going on when they say yes but all the time. You might look at the good things versus not the bad things, the not so good things. If you say bad things, that's got judgmental comments in it. Other things you can do is scaling questions. And these are questions like, on a scale of 1 to 10, how important is it for you to change your drinking? And you can also do the similar sort of question about confidence. How confident do you feel to change your drinking? Or how ready are you to make a change now? Just looking at brief interventions overall, the reviews of brief interventions regarding alcohol in pregnancy haven't been that impressive. Case management and home visits didn't find a lot of supportive evidence. Preconceptual interventions had a surprising indirect effect. They improved contraception for women who are drinking at hazardous levels, but it actually didn't reduce drinking. So that would delay or defer or maybe not prevent pregnancy. A single session of motivational interviewing was also not particularly effective. There's been some recent small studies on technological approaches, and these have had promising results, and it might be over the next few years we'll see a lot more in this space, using text messages, phone contact, and computer-based screening, computer-based motivational interviewing. Pharmacotherapy is an important part of management for general practitioners, but it's probably not so important in this particular area about pregnancy, because unfortunately most of the drugs that we use for substance use, for alcohol use in pregnancy were not looked at for safety and efficacy. Pregnant women were excluded in the research trials. However, there's been a rethink on this, and a Cochrane study suggested that rather than regarding them as being contraindicated, we should take a more nuanced or risk-benefit analysis towards using medications for drinking. Some authors have actually called for the use of acamprosate or naltrexone in pregnancy, although not disulfiram, as it is a known teratogen. When we're looking at smoking in pregnancy, there's good evidence that nicotine replacement therapy is safe, but not good evidence that it's effective, because unfortunately many women don't use it. They don't put it on, or they don't keep using it. Opioids, here we've got great news. We've got fabulous improvements in outcomes for mothers and for offspring using methadone and buprenorphine. When women are breastfeeding, if they continue to use the methadone and buprenorphine, that will allow a reduction, that sees a reduction in neonatal abstinence syndrome. And also buprenorphine seems to cause less neonatal abstinence syndrome than methadone. In the area of alcohol, over the next few years we might see some interesting research coming out about choline supplementation, and that might be even to the age of 4 for the offspring as a neurocognitive rescue therapy. One really important take-home message that I would like you to have for this webinar is the importance of talking to your pregnant women about relationships and working together with their partners. There's been a lot of work in the area of tobacco rather than alcohol on this matter, and studies have described how couples negotiate changes in the alcohol consumption through pregnancy. 3 patterns seem to emerge. One, conflictual, where there was tension or disagreement between the partners when there was a stop, or a reduction. Disengaged patterns, where people just did their own thing and thought it was the responsibility of the other to make their own decisions and do their own thing without feeling responsible for what effect on the other person. And accommodating, where each party tried to work out how they could look after their mutual interests by reducing together. It's so important that we raise the issue about the effect on the relationship with a woman who is drinking when we suggest changes. Because as I said, social and relational influence has a massive impact on people's drinking. And we've got to remember that if people just change their drinking when they're pregnant, it might cause relationship conflict, and that could cause relationship breakdown. There was a great self-help patient handout for tobacco, and that the link is there, and that will be provided after the webinar by the PHN. It's easy to read, patients can use it, even though it's talking about tobacco. Looking at the postpartum period and lactation, it's quite common in the West for women to use alcohol when they're breastfeeding. It's 20% in Canada, 39% in the US, and 60% of Australian breastfeeding women are using alcohol. How do we study this though? How do we get facts and evidence? Because it's hard to control and it's hard to standardise. How long after the drinking was the breastfeeding? Were people pumping and dumping, putting express breast milk for while they're drinking and then waiting some hours till they breastfeed? But both Australian and US guidelines advise that drinking while breastfeeding is unsafe. I would say this is a really important time to talk to your patients because it's a great golden opportunity for screening. About over half of women who are breastfeeding or are postnatal and drinking are trying to get pregnant again, or they're not using birth control. So this is the golden opportunity to get in before conception and give those excellent preventative messages. I next want to talk about the male role. And we've talked about me too, and I'd like to say we've got to look at him too, or maybe us too. And the blokes seem to be, as I said in the beginning, the invisible partner, perhaps the innocent onlooker in this whole thing about pregnancy and alcohol. Sorry guys, you can't get away that easily. And blokes have got a role from a psychosocial point of view, from a genetic point of view, and an epigenetic point of view. Psychosocially, we've got to think that pregnancies and a new baby are a massive change for a relationship. And that can be really exciting, really positive, or it can be negative. It can cause family violence or relationship breakdowns. Qualitative work with women who have had relationship breakdown during pregnancy finds that they report shame. They feel discriminated against. They might experience homelessness. And they report high levels of stress regarding parenting of the baby to come or their current children, and also financial and economic disaster at times. Such stresses can trigger more drinking. Looking at genetic effects from the bloke, we know that about 50% of alcohol use disorder is heritable, and we know that from twin studies and from adoption studies. And other biases or causes of confounding could be maternal drinking in utero, whether the parents provide a nurturing environment for the raising of their offspring, and epigenetics. And I'd like to look at epigenetics here. They often look at things like age and the environment. For example, the age of the father, epigenetically, we know that you see older dads have increased risk of schizophrenia in their offspring, autism and birth defects. If we look at malnutrition, you think about the Dutch famine during World War II, we know that both extreme malnutrition and extreme obesity in the fathers will have impact on their offspring. By epigenetic, we mean alterations in gene expression that do not involve changes in the germline DNA, and these changes can be passed down through generations. Looking at smoking, we've got some good research about congenital heart disease and epigenetically. There's more influence from the male smoking or maternal passive smoking than from maternal active smoking in terms of the impact on congenital heart disease. Also, certain childhood cancers, asthma, it leads to increased time to pregnancy and reduced semen quality. Although that latter one will reduce if the bloke stops smoking. Cannabis has got some interesting effects. We actually there's less evidence, concerning evidence about cannabis. In fact, there's some positive stuff from IVF studies. Some studies have suggested that it increases implantation and live birth rates. But the opposite is so with paternal tobacco and alcohol use. But we GPs just about never talk about preconceptual counselling with blokes. The only time we ever talk about that is when we're talking about men who are infertile. So this is an area where we've got to start looking at talking to our patients about. When we look at alcohol, we can look at mice studies. This is quite helpful because male mice can be given alcohol and then copulate and then separated from the female mouse and the offspring forever. Now, a lot of blokes would say it'd be very tough to be a lab rat. But I want to talk about some of these studies we've got. Now, when we look at male rats that do the equivalent of binge drinking, we can look at their offspring and they seem to have worse coordination and more behavioural problems such as risky behaviours. When we look, we can give also male rats chronic low doses of alcohol and then separate them. And we find their offspring have changes in the way they respond to alcohol. They are more sensitive to the rewarding aspects of alcohol. So that's quite an interesting change to see. When we look at human studies, we know that fathers who have alcohol use disorder have children who have behavioural problems, especially ADHD. If the father with alcohol use disorder is in remission, the children tend to have less behavioural problems than ADHD. There was a very large Shanghai study, 796 children born to fathers who reported drinking alcohol at least weekly. And the children, when they were checked at ages 4 and 6, had increased emotional problems, behavioural problems, and sleep problems. So, at the moment, we don't have any guidelines for prospective fathers, and they're certainly needed. We need to start having guidelines for fathers, and we need to talk to fathers, and we also need to have guidelines and conversations with sperm donors. So I'd like to talk a little bit about offspring of prenatal alcohol exposure pregnancies. Youth who are diagnosed with FASD have been found to have high rates of adverse childhood experiences. In the United States, it's suggested that's even double. One adverse childhood experience is the issue of being brought up by people not your biological parents, and over 98% were in that situation. We also found, and when we look at levels of trauma in children, the conduct disorders and the oppositional behaviour is very strongly related to the high levels of trauma in these children with the FASD. These children at 19 are more likely to be using alcohol, cannabis and cigarettes as well. And when on the last one about the childhood traumas, it shows that when we're dealing with disadvantaged children or FASD children, we need to really have a trauma-informed and culturally sensitive approach, because these young people have often had a terrible time since birth. When we look at persons with FASD, we know that they have a lower life expectancy. And we look at reasons that they die, and it's external causes. So they're things like accidents, overdoses, and very high rates of suicide. When we look at the equivalent of FASD in mice, there's a whole lot of changes too. And one I wanted to bring to your attention was changes in respiratory system, breathing frequency, and the response to hypoxia. So if there's a reduced response to hypoxia, and we see that in humans, then that could be a trigger for sudden infant death syndrome. So given that it's very hard to catch people before they're pregnant, and we tend to only at best catch them after they know they're pregnant, we need to look at the big picture. We need to look at changing policy. Because can our health system keep up with the proposed caseloads that we're going to see with FASD? And I'd argue that we really can't, because we're only picking up 1% of FASD at the moment. The NDIS is already struggling to keep up, and I just wonder whether we're going to be able to get researchers and experts on the same page as government so that we can actually get good outcomes for our patients and those people with FASD. We need to see public health policies that are based on evidence, and we've got lots of them. We need to stop just looking at those people who are irresponsible mothers. There's things that we can be calling for are reduction in alcohol retail outlet densities, reducing the number of days of sales for alcohol, reducing the hours of sale for alcohol, volumetric taxation, which means taxation by alcohol amount rather than what sort of beverage it is. At the moment, cask wine's got no taxation. And also some sort of minimal retail pricing, so two drinks, pay for one, get 2 drinks at happy hours, and very cheap alcohol in bulk. And I think when we're looking at this year, when we're seeing a voice referendum coming up, I think it's important that doctors should publicly support the yes vote to ensure that health and social policies that are going to be affecting our First Nations people don't ignore those people with lived experience, and that they can be involved in decisions that are affecting their life and society. All right. So we've got some multiple choice questions. Do we want to do those? How do we go to that?
First poll is open.
So what do I do here? Do you want
to talk through your first question? And I've opened up the poll on Slido.
All right, sure. So will I just talk to it now?
Yep.
Okay. Rightio. First question is, Australian alcohol guidelines advise to avoid any or all risk of alcohol-related disease or injury. Healthy men and women should avoid drinking more than 2 standard drinks a day. Under 18-year-olds should limit their drinking to no more than 6 standard drinks per week. Our guidelines advise, if you're male and planning a family, to avoid all alcohol. If you're female and planning a family, avoid all alcohol. And the last option is all of the above. So
So
the
Slido poll should be open now, so people watching at home should be seeing it on their screen, and they should be able to choose the option.
Is it working?
Sure. Oh, I don't think I gave people enough time. 3 people did get on, but maybe I didn't. I might not have left them enough time.
All right.
Maybe let's try the second question.
So we could talk about the first question, then we'll try and do the second question
Okay,
better, right?
sure. Yep.
So it was a tricky question, just like you're used to at medical school. And drinking more, sticking to under 2 or less standard drinks a day will reduce your risks of alcohol-related problems, but not avoid all the risks. There's under 18s, while they're more prone to binge than drink in moderation, there's no particular recommendation about their drinking. There's about males and planning a family, avoid alcohol. There's no guideline reference to males at all. If female and planning a family, avoid all alcohol, that is in the guideline, and all of the above is not right. Okay.
Perfect.
We're
People are
ready for
now
question
onto the Slido. So yes, and I'll show you after you've.
Right, we'll
Yep.
go through number 2. We're looking at fetal alcohol syndrome. Fetal alcohol syndrome occurs in 1 in 13 live births in Australia. Fetal alcohol syndrome occurs in 1 in 67 live births in Australia. FASD is an unknown prevalence in Australia. And fetal alcohol syndrome is a diagnosis characteristic of our First Nations people.
75% of people have chosen option 2 and 25% have chosen option 3. Shall I show the correct answer?
Yep.
Oops.
So we actually don't know how common FASD is in Australia. And we know that it's not related to race, it's related to alcohol consumption. And the 1 in 13, 1 in 67 came from global studies about the 10% of women who drink and what rates of FASD will we see in their offspring. So then the third of our 4 questions is about male partners. Male partners of pregnant women have a role in, here's the 4 options, ensuring their women cannot access smokes, alcohol or drugs. Male partners should be reporting any drug or alcohol use to the authorities. Male partners should be avoiding drugs or alcohol well before planning a pregnancy. Male partners of pregnant women have a role in ensuring their women can cope with the stress of pregnancy by drinking in moderation.
I think everyone's got that one.
Yep, they've got that one 100%. That's pretty impressive.
Yeah.
Okay. But I don't have a good poker face. Now, the last one is about fetal alcohol syndrome. It can be excluded if all the screening questionnaires were negative. It must be based on alcohol consumed after the recognition of pregnancy. Fetal alcohol syndrome requires GPs to seek an alcohol history from mothers of those with FASD-like close-set eyes and low IQs. FASD remains undiagnosed in an estimated 25% of cases. And FASD is more common in families with 1 child already diagnosed.
We've got a 50-50 on this one.
All right. So screening questionnaires we've already talked about. Often you see underreporting because of shame, guilt, fear of legal or custody consequences. It can be related to alcohol before conception, between conception, recognition of pregnancy, or afterwards. When we take, I didn't actually mention this, but when we look at retrospective screening of women about alcohol use during the pregnancy, when children are young, like primary school, women tend to very much underreport. But once they're in the secondary school, they're much more likely to report. And that's because they're going to access support or even financial or educational support. And remains undiagnosed, estimated 25%. It's actually 99% of cases. And it is true, FASD is more common in families with 1 child already diagnosed.
7% got that.
All right. There we are.
There we
So
are.
back to you, Sandra.
Great, fantastic. Here I come. You can leave those if you like. Well, firstly, I just want to thank Emma and Simon for those amazing presentations. That was just fantastic. They were very thoughtful, very intelligent, very well researched, and thank you so much for sharing all that knowledge with us and your experience and your expertise. And I'm sure that many people online who are watching got a lot out of that. Would love it if you have any questions. We've got Emma and Simon for a little bit longer. If there are some questions buzzing around in your head, please pop them in via Slido and I'll have a look just after I show you quickly around the Health Pathway site. And I'm hoping that Health Pathways is not new for anyone who's listening, but just in case it is, firstly, I'm just going to start with the login. You can use the QR code to get in if you like. And then the username is H&E Health, all lowercase. And the password is Pathways, but each A has been replaced by a 1, and again, all lowercase. So I encourage you while we're talking to log in on your iPad, on your phone, on your computer, whatever device you've got handy, and have a little play as I'm talking so you can experience the site and have a little feel and follow along as I'm talking. We also have a sister site called Patient Info, and this site is where we house all the information you can give out to your patients. All of this has been vetted by a clinical editor as being up-to-date, current, evidence-based, and in line with all the pathways that we have published on the site. So Todd, do I just turn this off and go to the, is that right? Almost. Thank you, Todd. Todd's been with us since we started doing webinars during COVID, and he's just been an amazing support during all these live stream webinars, and is quite the man to have by your side. Thank you so much. So this is the Hunter New England Community Health Pathway site. Hopefully you've all managed to log in. And I'm just going to show you some of the really pertinent things that relate to the talks that we've heard tonight. For those of you who've never used it before, there are 2 different ways of searching the site. You can either go up to the top here in the search engine, or if you know what you're looking for, you can go down the left here into the table of contents. But I'm just going to use the search engine tonight and just put a few little things in just to show you a few relevant pathways. So the first one we've heard a lot about tonight is FASD. We've got a FASD pathway that was written in collaboration with Murray Webber, who's a paediatrician at Hunter New England Health. That was written a number of years ago now, but all of our pathways are reviewed every 2 or 3 years. And what we really love is the feedback button, which is in the bottom right-hand corner of every single pathway. If you see something you don't think is quite correct, something doesn't make sense, something you'd like a bit more information on, if you just want to say, great job, Health Pathways, love your pathway, please send feedback. We check it each and every working day, and we do respond to all feedback. So this FASD pathway is set out like all our pathways. We've got a little bit of background at the top, hidden down in these drop-down boxes, and then assessment, management, referral. And it's all set out as a primary care clinician would do: history, examination, investigation. And then the management is all set out from most acute to least acute. And then at the bottom we have all of our referral options. And I'll show you a couple of those in a minute. But the other pathways I just want to show you, if you type alcohol in the search engine, if I could spell alcohol, so there's a range of alcohol pathways that come up. We're just going to go to brief intervention for a minute, and that's where you'll find the audit score, the Audit C assessment tool that we've heard a lot about tonight. And maybe I need to do a little bit of work with Simon for some of those other tools he was showing us. But I also want to just quickly go into one of the referral pages so you can just see what they look like. The Specialist Alcohol and Drug Services one is set out a little bit differently to our normal referral pages. But for example, if you would go to the clinical services part, you've got the private, the NGO and the public referral options for drug and alcohol treatment referrals. And if you pop down into these, here you can see under the Hunter New England Public Service, we've got the Substance Use in Pregnancy and Parenting Support, the SUPS, and a number of other programs that you might be interested in having a look at. The other one I wanted to show you very quickly was the Drug and Alcohol Specialist Advisory Service that you might want to call for advice. I don't know what you think, Simon, but they're an amazing source of wealth of information if you're looking for a bit of extra support. The other thing that Simon talked about tonight was the motivational interviewing, and we have a motivational interviewing pathway that was written by our very own Jamie Navali. So that would be one I'd love to have a look at with you too, Simon, to see if there's something that could be interesting to add there. And I think that is probably enough from me. I'm going to check Slido and just see if we've had any other questions come through. Todd, you're welcome to just shut that down. I don't quite know how to do that, but thank you for doing that. I can't see any questions that have come through on Slido, unfortunately. It's not too late, everyone, if you've got a burning question, but I certainly had just one or two. Simon, I was quite fascinated by the vaping evidence you put up, was there any thoughts in that paper around the mint and menthol flavour and the increased risk of stillbirth?
Okay. I think that's probably noise. I don't think we should have a particular warning on mint or menthol vapes for pregnant
Go for watermelon?
No. One of the frightening things about vaping is that almost all of them have got nicotine in them. And people often consume them quite innocently and end up with getting used to very high nicotine serum levels and a very high level nicotine dependency. And we're going to see a lot of young people coming through with that. And our standard nicotine replacement therapy won't really cut the mustard because it's a much lower dose than what they're getting from their vaping. It is a really big problem. It is being sold in our community as a way of helping people reduce their smoking. And there are some people who do reduce their smoking. A lot of people don't stop smoking. They often use both. And whether vaping is going to, over many years, we'll find all the cogeners and other electrolysis products in vaping is going to cause their own chronic diseases. We don't know.
Yeah, absolutely.
We've got no idea about pregnancy, and I would be very surprised if we'll find that vaping is anything but a disaster for pregnancy.
Yes, I'm curious to see what's going to be happening with this, the big budget announcement that they made and all the money that they're investing now in trying to stop vaping, and hoping that that's going to be a move in the right direction. Have you got any thoughts on that?
Hard to know how we'll assess public health issues like this because it'll take many years for the impact to come through. I think that there are going to be some people that will find vaping help them reduce their tobacco smoking, and perhaps putting it on a pathway through the pharmacies will help. Driving it underground by making it criminal doesn't work. We know prohibition didn't work with opium, with morphine, with the opium dens, alcohol, with, Al Capone was only caught by the taxation people. So criminalisation doesn't work. We need to regulate it. Regulating it through the health system is, probably better than unregulated, but there are going to be issues there.
Yeah, no, I 100% agree, and and as you say, vaping has just gone astronomically, on the increase. So, need to turn that curve around. My other question is for our primary care clinicians who are dialing in tonight and having a listen. Where can they go, do you think, for some support or for some good referrals or for some good community support to help them support these patients? Because we look at the primary care model we have and you've got so much time with the patient. So I imagine it's a bit of a team sport for these patients, for managing them, or is it, what are your thoughts on that?
Well, I think we got to be thinking about this when people aren't pregnant. And I think we've got to keep our ear to the ground and be comfortable engaging with people about their lifestyle right from the word go. We know that the more hazardous and numerous are the intoxicants that people are using through pregnancy, the less likely they are to get antenatal care. So it does make it very difficult for us. I think we have to be really comfortable talking to people about their tobacco, alcohol, illicit drug use, and now their vaping, talking to them and exploring whether they want to make healthy choices or not, and the importance, how important health is with them. And if we're doing that in the background long term, I think that'd be better than just trying to catch people once they're pregnant and then shaking our finger at them. Yeah,
moving more to that prevention rather than reactivity, absolutely. Emma, I hope this question doesn't pop you on the spot, but if you were hoping for one message to come through from your talk tonight or your presentation, what would it be? Your top 1, 2 or 3 things you're hoping clinicians might change, do better, or take away from your presentation tonight?
Yep. So for me, I think it's that, clinicians aren't alone in this, that there are, that there's support out there. So there are, campaigns and projects like the Every Moment Matters project. There's the Strong Born campaign that's out there at the moment as well, that provide really some fantastic resources. Also on their website, there's great links to kind of other kind of services that are available that they can refer to. Similarly with Health Pathways, that shows great services also and helps clinicians step through those processes. So not to think that that you're alone in this journey, but connecting into what's out there already.
Absolutely. And same question for you, Simon. What's your 1, 2 or 3 top things you'd like clinicians to take away, or something you're hoping they'd walk away and do things just a little bit differently? I know we've heard a lot about emphasis moving more towards prevention and the prenatal care, but were there some other messages you're hoping they'd walk away with?
I think we need to remember that people use drugs and alcohol for a reason, and we need to listen to those reasons and help them explore the decisions they're making and consider the consequences and how they can go about making those changes. And perhaps those changes can be done, and hopefully they can be done in collaboration with their family or their friends.
Well, thank you. Thank you so much. It's been just so wonderful having you both here tonight. And thank you, Simon, for driving down from Taree for this. We really appreciate that. And thank you all for dialing in, for giving up your Tuesday night to come and share this webinar with us. And hope you have a lovely sleep. Good night.